Hello, welcome to the Better Outcomes Show, where we explore the possibilities of a new healthcare. Each episode, we bring you a conversation with leaders across the healthcare industry, exploring topics ranging from new treatment techniques and interventions to novel service delivery methods and business models. And now your host, Rafi Salazar from REHAB Practice Solutions, a leader in patient engagement and retention strategy. Let's explore the possibilities of a new healthcare.
Well, hey everybody, welcome to another episode of the Better Outcomes Show. I'm your host, Rafi Salazar from REHAB Practice Solutions. If you're new, thanks for showing up. Thanks for giving us a little bit of your time. Hopefully by the end of this episode, you'll be hooked. If you're a returning listener, thanks guys for sharing the show, for spreading it around your networks with your friends. It helps people find us. It helps expand our reach and help us fulfill our mission, which is helping clinicians and healthcare organizations improve the service delivery that they offer to their patients and their clients. In line with that, our guest this week, or my guest this week, is a guy named Craig Solid. He's a PhD, and his job is not like most of the other folks we've had on the show. Much of the content recently has been around how do we leverage technology or how do we leverage nature in one of these last episodes, or understanding a biopsychosocial model and how does that impact the way we deliver care, or how does it inform the clinical decision making that we have around delivering care specifically to patients. Craig's job, he's a consultant, and what he really helps his clients do is justify the return on investment for quality improvement initiatives. Now that sounds super, super dry, I understand, because no one wants to talk about investment and return on investment and all the bland statistics that go into making changes at a healthcare organization. But if you think about it, it really is a very, very important part of the healthcare system, right? Like if a quality improvement measure doesn't get implemented, then the quality doesn't improve, right? The service delivery doesn't improve. And sometimes, depending on the stakeholders involved, you need to prove that what you're doing is going to be financially viable, financially acceptable in the long run, insofar as getting some of those stakeholders on board. So Craig and I had a long conversation about just what is value in healthcare? Like, how do you measure it? And again, value is very subjective. So who are the stakeholders involved in this decision, and how are they looking at the situation, or how are they looking at the proposal you're putting forward in regards to the value that it might provide to the organization? Because there are some things that are highly valuable and very intangible or hard to objectively measure. And then there are some things that might be very tangible and objectively measured for some stakeholders, but not to the end user, which might be the patient, right? So we have a conversation around all of that. How do we measure value? What is value? How do we prove that what we're going to do, or what we're proposing to do, is going to have a real objective outcomes? And how do we get it all to work, right? Like, how do we get all of the stakeholders that might be involved in the decision making, and then on board with implementing whatever quality improvement initiative or change that we want to put forward? So hopefully you find some value in this conversation, that you take some practical tidbits away when it comes to justifying things you might want to do to higher ups, or if you're in the higher up position, to justifying it to stakeholders. Without further ado, here's Craig Solid talking about return on investment and the value in healthcare. Hey Craig, welcome to the show. How are you?
I'm great. Thanks for having me.
For those who don't know you, tell us a little bit about yourself, the work you do, and then the book that we're going to be discussing, which is all about return on investment, right?
Sure. I'm an independent consultant in the healthcare field. I work with physicians, nonprofit organizations, anyone who's doing research or quality improvement. And most of what I do relates to aspects of data and measurement and evaluation, one of which is the financial evaluation or return on investment. So I recently published a book. It's called Return on Investment for Healthcare Quality Improvement, and it really is kind of a guide for how do you determine what's the financial return for either what we're planning on doing or what we have already done.
Yeah. And when you're talking quality improvement, you're talking everything that covers things from, the effectiveness or the procedures of healthcare delivery all the way through to like patient experience and satisfaction, right?
Yeah, really anything and everything. Anything that an organization or a provider or facility or a health system wants to do to improve some aspect of care. That might be, internally focused so that it's efficiency, reducing waste. It might be patient focused, improving patient outcomes or their experience. Often it's related to some federally, monitoring program or some, national quality measures, but not always. So it kind of runs the gamut.
Yeah. Yeah. Because sometimes you've got the government coming out and saying, well, you've got to do XYZ. And sometimes it's just organizations trying to improve, right?
Yep, that's exactly right.
So, and I was reading through your book here, at least the first couple chapters, and in it, you start the book talking about this whole move away from a fee-for-service model or a fee-for-service payment system in healthcare, especially like here in the US where Medicare and CMS are beginning to try to move more towards a value-based system of reimbursement. What do you mean when you say a value-based system for those people that might not be aware?
Great question. So, at least how Medicare has defined it is they are starting to link reimbursement for physicians and for hospitals and providers to how these groups perform on specific quality measures. So they will look at the rate of rehospitalization within 30 days for a given hospital, and they'll compare that to every other hospital. And depending on where they fall, they may get a little bit of a bonus, they may receive less. So they're trying to tie the quality measure to the actual reimbursement. So there are all sorts of complicated factors that go into that, and there are discussions that go on about, is that appropriate and when is that appropriate and how can really compare there. But that's how Medicare thinks of it. In sort of the larger scope of value, it's really intended to be more patient focused. So what is the health of the patient after they have care, after they have been in the hospital, and how do you measure that, and what do you do about that? So instead of just reimbursing based on, we did these tests and we did these procedures and we gave this diagnosis, really trying to think more sort of holistically about, well, how did the patient do? What was their experience? How's their health now? And that's a really hard thing to measure and to quantify and to compare. And so often, value-based healthcare is sort of thrown around as a catch-all, when it might mean very different things to very different people, because obviously that care means different to the patient and their family than it does to the provider, and it means something still different to the payer who's actually paying for that service. So it can mean a lot of different things depending on your perspective.
Yeah, because in and of itself, value is subjective, right? So,
Right.
you bring up in the book, and it makes total sense. Like the payers, and you mentioned this, the payers are really wanting to pay for an outcome, right? Like that's
Mhm.
their value. They're it's almost like a merit-based payment system if they had their way. The
Yep.
patients or the ultimate end users or receivers of the healthcare services are wanting whatever kind of benefit they're perceiving as important, whether it be like a reduction in pain or a positive experience. And then the clinicians themselves or the internal stakeholders delivering on those services have their own their own metrics in their mind of what constitutes value-based care. So talk
Yep.
a little bit about that idea of value and its subjectivity and how maybe an administrator might look at it differently than a patient or even a payer would.
Well, sure. I mean, you're right. Value is subjective, and it's highly dependent on your perspective. So, a patient, what do they value in terms of care? They want to feel better. They want to have higher quality of life. And if you ask them, well, what's that worth to them? They probably won't be able to answer that. That's a very difficult thing for them to answer, especially in our healthcare system where they don't typically have a sense of what anything costs. So it can be very difficult to quantify and put an exact number on how a patient might value something. But they certainly value it differently than, say, a provider who they want to serve their patient, but they also are cognizant of the budgets that they have to sort of work within. And if you were to ask them what's high value care, they would probably talk about processes within their own facility, efficiencies, reductions of waste, the ability to, ensure that the patient gets the right the right care that when they need it. So it really becomes a conversation about who are we talking about, and then a payer, like you said, same thing. They're interested in the utilization that people have, how often they go to the physician, how long they have to stay in the hospital, and they're interested in actually reducing that to some extent. So they're perhaps willing to pay for something up front if they see the value in it in terms of reducing care down the road.
Yeah. Well, and just looking at some of the research out there, definitely the move is getting away from this fee for service model and more towards a value based model. I think one of the quotes in your book is that one of the projections is that 75% of payers and insurance groups in general are moving more towards like a value based arrangement, right? So how are they figuring it out or navigating those waters if it is so disparate depending on the stakeholder? Is this kind of an initiative that third-party payers are kind of plowing ahead, or in your experience, has there been some conversation with the other stakeholders at play?
No, I think this is one of the main problems is there's not a shared vernacular when people talk about value-based care. And so private payers have their own definition. They don't necessarily always share that, but they will use the phrase, and it's reasonable to assume that they mean some combination of better patient experience, better patient outcomes, and at the same time better efficiency, reduced waste, sort of so some combination of both sides, which really just kind of makes it even that much harder to sort of quantify it, because now you're trying to mix different perspectives into the same conversation. But across the industry, it really is something where it feels like people have said, hey, this is a good idea, let's push forward and do it, and kind of figure it out as we go. So depending on who you talk to, they're going to have a different sense of what this means, and also a different sense of how important it is, and where it can be applied and where it may not be able to be applied.
Yeah. And even outside of the payers too, there's more of the drive. I've been saying it for years that the internet came and
Mm-hmm.
patients became much more aware of at least their options. And even in your book, you say, quote, patients on the other hand are demanding more of their care experience and encounters, including the recent push for price transparency. Whether they realize it or not, they're really pushing for a better understanding of the value of the care they are receiving. So talk a
Yep.
little bit about that and how this shift of, for a while it's been healthcare has been driven by the administrators, by the payers, but now we've got this other complication, which is the end user is
Mm-hmm.
finally starting to have a little bit of say, right?
Yeah, I mean, it's an interesting dynamic, and the history of the healthcare expense in this country. A lot of people will tell you what's driven how expensive it is really the price. Um, it, Prices have risen dramatically, in part, some would say, because patients, the users, are kind of price insensitive because they don't necessarily see the price. They pay their premiums, and they go to the physician, and they maybe have a copay, but they don't really see how much something costs. And even physicians often, if you were to ask them, well, if I need an MRI, how much is that going to cost? Most likely they're going to say, I have no idea. That's the billing department. So there's been this, lack of price transparency, and that's really driven it. And I think, patients are demanding better experiences, and they're also trying to understand, well, what am I actually paying for? You see news reports of people getting these sort of surprise huge bills and things like that. And that's the extreme case, when they had no idea what it would cost, and then they look at the bill and they see some outrageous price for an aspirin or something like that. And of course they would never have decided to do that. And from an economist standpoint, that's an incredibly inefficient use of those funds. The hypothetical for an economist is to say, well, one way to test its efficiency is to say, pretend you were to give that money to the patient. How much of that would they actually spend on that care, and how much would they pocket themselves? And so if you do that, a lot of times you find a lot of this is, from an economist standpoint, pretty inefficient. But patients are pushing for better experiences, and some would say across the board, individuals are pushing for better experiences in whatever they do and whatever they're consuming across the economy. But providers are now finding that they're having to deal with comments on Facebook and Twitter and reactions of patients, and the sort of word of mouth that goes along with that. So they're understanding that the value is not just driven by the outcome that they can report to a federal agency or to a payer, but they're also in some ways more accountable to patients, because they know that those patients are going to then talk to other potential patients, and there's going to be sort of a groundswell of okay, well, what's this worth? Where's the value in this for me?
Yeah. Well, and even some of the research coming out on the clinical side of things, as far as clinical outcomes and satisfaction with care, you would, as a clinician anyways, I would tend to think like, oh, if I've got great technical skills and I can, get some kind of positive outcome, clinical measurable outcome, objective measure improvement for my patients, they're going to have a positive experience and they'll rate me well. But you go back and look at the literature, they are very much hinged on the interpersonal interactions, or like the
Yep.
intangibles is what patients really weigh, oftentimes more than the technical skills of their clinician.
Yes. Well, and these days too, and I don't really touch on this in the book, but the social determinants of care and the access to care is a huge aspect of the value of the overall healthcare system, and it's one that hasn't received a lot of attention until the last several years. So the interaction and the intangibles that you talk about, there's a lot in terms of value to sort of explore as it relates to vulnerable populations, underserved populations, those with less access to care, whether it's because of geography or socioeconomic status or whatever. It is a really big deal. And right now, with everything happening and the advance of telemedicine, there's even more sort of disparities being identified. There's sort of a technological disparity. So the value, as we think of it, we kind of need to start thinking of it holistically across the spectrum. It's not just about what happens when a patient enters the hospital and when they leave. It's about how the entire system sort of supports their health, and how do we get the most value out of what we're putting in.
Yeah. Which kind of moves into the whole topic of your book, which is, if an organization is looking at improving the quality or the value that they provide, oftentimes it's very difficult to develop or to justify to administration or executives how the amount of money that they're going to spend on a quality improvement initiative, which can sometimes be significantly expensive, how
Yeah.
that's going to translate into the dollars and cents improvement on the other side. Because like you said, how do you qualify or quantify a patient not going and putting a bad rate my doctor review or a Google review? Or how do
Yeah.
you rate the return on investment for them going and having a positive review on those on Google or something like that?
Yeah. Well, I mean, it's hard because you're right. I mean, a lot of the metrics that we use to define the quality of care, like patient experience, reduction in, say, caregiver burden, happiness, satisfaction, those are not only intangibles but really hard to monetize. And so how do you justify, let's spend this much money when the main outcome is something that we can't actually tie a dollar value to? And so in the book, I try and sort of toe the line between, you know, trumpeting the fact that return on investment is just one aspect of value. And if you're actually looking for the sort of overall value of a project or an intervention or something, you want to look at more than just the financials, because these intangibles are things that are important and things that we historically we historically know are important. But at the same time, there are things that can be done in terms of when you're thinking of it and planning it to say, okay, how am I going to be sure that this, in addition to providing these intangibles and the improvements in quality, how can I be sure that it will also demonstrate a financial gain so that it's sort of a win-win? It's a no-brainer for those who are funding it, whether it's an external funding agency or internal administration, to say, yes, that'll make patients' lives better and it'll save us money in the long run. And really, one of the things I try and promote is just thinking about that and approaching these things from the beginning in that way, as opposed to what's typically done. Something's planned or it's done, and then retrospectively someone says, oh, what was the value of that? And it turns out, just because of how it was done or how data was collected, the information just isn't there to be able to do a viable value assessment, and certainly not a return on investment calculation. So it's really about balancing those things, but also being cognizant of them so that you can take them into account when you're planning and thinking of doing these.
Yeah. Well, and I think that's probably been, when I think about value-based healthcare, that's probably been one of my biggest hangups on the idea of it, is that, I don't know if you've read any of the work on by McDavitt and Wilkinson about value-based pricing, or even Ron Baker talks about it a little bit. But there's three components of value. One of them is revenue gains. The other is cost reduction, and then you have that whole messy gray area, which is emotional contribution to value. So
Yep.
when we get into the weeds, or get into the ins and outs of actually, how is Medicare or CMS or whatever third party payer taking that emotional contribution to value into account when they're setting reimbursement rates? And I would contend that the answer is they're not, at least not on
Yeah.
the part of the patient, right? They're
Well,
looking more at the efficiencies and the value for that organization.
yes. I mean, they're trying. I mean, it's the HCAHPS survey is, it's a patient survey, and it's about their, patient experience, and ratings on those surveys will affect some of the reimbursement. But you're right. And some of this comes down to sort of basic concepts of measurement and evaluation. And I talk about this in the book too. A lot of people talk about these intangible and tangible aspects. And I, to get more technical about it in the book, I talk about things that are measurable, monetizable, and attributable, because tangible, intangible is a little amorphous. Whereas if you can measure it, if you can, and it's a valid and reliable measure of what you're trying to measure, you can apply some sort of money value to it, and you can attribute it to what you've done. Then you can sort of include that as, okay, that's a result of what we did in a specific and a specific return that we can quantify. One of the things that Medicare is running into, for example, is, they say they tie reimbursement to rehospitalization rates. Well, that's measurable and it's monetizable, but one of the things they're running into is it attributable? A lot of
Yeah.
people will come along and say, hey, readmission rates were already decreasing, or you can't compare our hospital to that hospital because of case mix. Even if you sort of risk adjust, it's just not fair. So depending on your ability to do this and assess value at its heart is really based on how good your metrics and how good your measurements are. And that's sort of way upstream to sort of establish that. And again, the rehospitalization is sort of a favorite example of mine, because if you were to ask that individual hospital, well, what do you think is a good metric of your quality? There's no way that they would say, well, how many of our patients return in 30 days is certainly a measure of how well we did. They're going to say there's a whole slew of things that can happen to patients, including their own behaviors and choices, which can influence whether or not they need to be, come back to the hospital. Only thing we can control is what's done in our door. So it's really that push and pull that Medicare is trying to figure out, and those across the industry are trying to figure out. And so I just want us to have more conversations about it and try and gain a shared, language and vernacular about what we're talking about when we talk about value, and get people to think about some of these measurement issues and concepts when they're, as opposed to just throwing around the term value-based care.
Yeah. Well, and I like that quote from your book too. You say, the goal is to establish a definition or a common vernacular about what value is in healthcare. And then specifically, we need to address that, or understand that for each unique case, you need a framework to operate in, where an established scope and perspective will allow us to consistently and reliably identify and quantify the associated costs and benefits, which is a whole lot different than saying like, this is value-based care. You're talking like every case is different, but here's a framework that we're going to use. So talk a little bit about the framework that you would suggest and kind of how we should think about, okay, a quality improvement initiative or even a clinical improvement initiative, and how we begin thinking about it in terms of value across the system.
Sure. I mean, so the first thing that I tell people is you have to get clear about your scope and your perspective. So the perspective is really, who are we talking about? Who return, when it comes to return on investment, return for whom? So often their groups say, hey, we want to figure out what the return is on this. And return for whom? For you, for patients, for payers, for administrators, because it's going to differ depending on whose perspective you're talking. Society's benefit, it's really going to differ. And then the scope really is about, who's included and over what time period. This can get hard because often when, especially in quality improvement, there might be an initiative, whether it's an education system or a new, piece of hardware or something like that, where there's a large cost up front. But if it's doing what it's supposed to be doing and you're improving care and, improving outcomes, hopefully it will do that for a long period of time. It's hopefully sustainable. So the return really is a function of how far into the future you go to sort of accumulate those benefits from that either one-time cost or sort of the cost plus the small maintenance cost. So what I tell people is when you think about these things, you need to think of it as, okay, on the back end, how am I going to look at this? Whose perspective? And if there are multiple perspectives, that's okay, but you probably want to do separate analyses. And then over what time period? Are we talking about 6 months, a year, 10 years? What are we comfortable with and what do we think is reasonable? So a lot of times just starting with that will allow people to really frame what are they going to measure, how are they going to measure it, and what will it do for them? So that's really the first step of it.
Yeah, and some of those questions you have in your book are like, how will we define quality in this situation? How do we define value? Talk to us a little bit about, so let's say maybe a hospital group, an executive C-suite is looking at doing some sort of quality improvement initiative, and they want to get the ball rolling on the idea. How would you structure or lead them through this idea of determining what the quality and what the value is based off some of those questions?
Yeah, so that's a good question. So, and a lot of these groups, they have experience thinking about quality, and they over the years have learned that, hey, quality doesn't just mean one thing in one situation. We have to get specific about what does quality mean in this situation, and how are we going to measure it, and what data do we have available to us. And the same is true for value. And so I would lead them through that conversation and say, well, how do you measure quality in this situation? What would be a quality of care here? And then at the same time, you really need to talk about data at the same time. Okay, to measure that, what data would you need? Do you have that data? Can you get that data? Because a lot, like you said, a lot of these things are intangibles, and it may just be not possible to have certain data. So that can adjust. Okay, well, how are we going to think about how we measure quality given the data that we have? And the example I use in the book is, I say, if you think about concepts like happiness or satisfaction, if you just ask someone, well, what's satisfaction mean? They're going to talk to you about emotions and feelings and things like that. And then if you say, well, define satisfaction in a way that I can measure it and track it, and they say, oh, well, then we maybe use a Likert scale of, very satisfied, somewhat satisfied, that whole thing. And so you're describing it differently depending on the data that you have, and assessing value is no different. So you think about the data that you have, you ask yourself, how are we going to measure it? What would value be? From whose perspective? Are we trying to get the patient's value, our value? And then how would we actually use that data to calculate the different metrics that we want to look at?
Yeah, yeah. And I think I'm reading through right now, and you're talking about how this is done for like a single perspective, or you're trying to do this globally? Because you're saying, like in your book, you're saying ROI primarily is a representation of monetary returns from a single perspective, while value, on the other hand, should be taking into account a wider perspective.
Right.
So are we
Yeah.
looking at developing, a measure of ROI for maybe all three stakeholders in every initiative, or how does that look?
That's a good question. And I think really, my point in the book is that typically an ROI analysis is not done in a vacuum. It's done as part of a larger either proposal or summary report. And in either case, whether it's to motivate the fact that this should be done and should be paid for, or to demonstrate that it was worth doing, you're not only going to want to talk about the financial returns, but you will want to talk about the larger value. And so it's completely reasonable to say, for example, if you're going to, if you were within a facility that was going to fund their own initiative, it's sort of two pieces of value. You could talk about, okay, financially, here's how our facility is going to be better off. Okay, we're going to increase demand. We're going to have more available beds. We're going to have a larger share of, insurance pools, risk pools, things like that. And beyond the financial part, the overall value, we're going to improve care for patients. We're going to improve their satisfaction. We're going to improve, our brand in the community, things like that, even though we can't measure it. So it's important to sort of put those in there at the same time that you're talking about the financial return. So you wouldn't necessarily need to do an ROI for each individual perspective. Often the perspective you're interested in is whoever's going to be paying for it, right? So
Yeah.
if you're trying to convince NIH or CMS to fund something, you want to do the perspective from their point of view. What are they paying and what are they going to get out of it? And then when you're talking about the larger value, you not only incorporate that piece of it, but you then talk about the larger value to the system as in a whole, in entirety, whether that's patients, providers, the whole healthcare system, things like that.
Yeah, so the ROI isn't the end all be all. And even looking at your illustration here, it's like the little puzzle piece in the corner, but there's also, caregiver burden, efficiency, quality, quality of life, patient outcomes, all of that kind of blends together to create what we call the value, right?
Yeah, and I think that's one of the main messages I want to get across is I think ROI and value are used interchangeably by a lot of groups, and I want to get away from that. The ROI is one piece of that puzzle that you described, and it's a very specific piece. You had said previously value is subjective. That's true. ROI isn't, and it shouldn't be.
Yeah.
It is. We need to have a framework that talks about it in specific terms, and that piece of it is a very objective calculation that we can use to assess the financial impacts of something that we're either planning to do or did. But the overall value is a larger piece that involves a lot of other things.
Yeah. Well, then let's talk a little bit about, dive a little deeper into the idea of ROI as being what we're measuring. In your book, you talk about I think it's 4 challenges, right? Or the 4 challenges for assessing or measuring ROI, for determining ROI, right?
Yep.
All right. Do you know them? Do you want to go just 1, 2, 3, 4, or do you want to kind of talk about them?
Why don't you take me through each one?
Okay. So the first one, you say, usually several different perspectives could be considered for any given quality improvement initiative, such as those of a patient, provider, payer, society, etc.
Right. So in this one, this is where, and you alluded to it, but this is where groups can sort of get paralyzed. They don't really know where to start.
Uh-huh.
They say, well, we have what's included. What do we gather? How are we possibly going to quantify all these different aspects of the value of the care for all these different groups? And so that's why, even though ROI needs to be done from a single perspective, the challenge is that, unlike perhaps in, say, manufacturing or sales or something like that, there inherently are other people who will receive benefits and incur costs. If you start an initiative at a facility and you're getting external funding, maybe you're doing ROI from that external funder's perspective, but the physicians, the nurses, the staff who are investing time, they're incurring a cost in terms of their time. And whether or not they receive a benefit may depend on the situation. Patients who have to sort of, maybe they incur a cost in terms of lost work and lost productivity to be involved in whatever study or something like that. Those are all important aspects, but they aren't necessarily included in the ROI that you will do to justify it to the external funder. And so that can be one of the challenges. There's just so much going on.
Yeah. Well, and part of that too, like, I think in the book you talk about, how sometimes a gain in one, because there are different perspectives, is a loss for the other, right? Like,
Hmm.
decreased hospital admissions is great for Medicare because they're not paying for it, but it's bad for the hospital because it means there's a revenue loss of some kind. So I'm assuming at some point here, you're also dealing with kind of the behavioral economics or the economics incentives created by whatever initiative they're thinking about doing, right?
Definitely, and that's certainly, and that's one of the difficulties of trying to incorporate everything at once. Is you're right, some things that are a cost to one group are a benefit to the other, and those who are trying to go to value-based care have to certainly be conscious of the incentives that they're creating, even if they don't realize it. Right. So if you base your reimbursement based on some relative performance, there are times when you may encourage a group to work really hard to stay at 95, 98% in some performance measure, whereas they're performing at 50% somewhere else, but it would take so much for them to get to a point where it would change the reimbursement that they would rather invest, time and effort to stay really high on the one measure than in the one where they actually could really use the improvement. So those things certainly have to be juggled as you think of all these.
Yeah, I mean, I think that the whole point of gosh, what's his name, Hazlitt's book, "The Economics of One Lesson," is all about that, right? Like
Yep.
unintended consequences or incentives created by regulation here or rule there.
Yeah, and of course there are internal pressures, right? I mean, there's internal budgets, there's different regulations, there's and then the reality that every healthcare delivery system is unique in some way. It's none of these are factories that are you just have parts that can just be replaced easily. So all of that has to be considered when you're thinking of these things.
Yeah. So that wraps up one, which is that there's a bunch of different perspectives. The second challenge you note in your book is that there's this notion that a good quality improvement intervention not only improves care, but it also is sustainable for the foreseeable future.
Yeah, and this really speaks to the scope. So, improving care is one thing. And when you have evidence-based solutions, you say, hey, this works, we know it works. Well, implementing that solution in a care delivery system is a whole nother ball of wax, I guess. So, and there's a whole industry of implementation science that looks into how to do that. And most would agree that a good intervention is one that's sustainable, the one that can be continued for the foreseeable future. So if you're trying to say, well, what's the financial return? Well, as of when? Because the longer
Yeah.
that's sustained, the better and better and better financially it's going to look, even if you discount, on a yearly basis. So it makes it difficult to come up with, well, what's an appropriate scope? What's an appropriate length of time? And that is going to differ depending on the situation and the organization and the project that's being implemented.
Yeah. Well, and I'm assuming it also has some implications for like the longevity almost of something. Like I'm thinking like marginal utility curves or something like that, where yeah, like the first 3-4 years of implementing this, the costs are really really high, and for maybe a marginal benefit. But um, as you get further out, maybe it increases, or maybe it's the other way around, where the first couple of years of instituting this initiative, the results you get are super super high, and then it kind of tapers off. So
Yeah,
that plays a role in this, doesn't it?
certainly it does, especially if you are trying to monitor your financial return as you go. So if you have a situation where you have a large lump sum up front, and maybe there's a delay in the benefits that you're going to see, if it's an educational program, if it's a community outreach program, there might be weeks or even months before you actually see a tangible benefit. All that time you're incurring cost, and if you run a return uh, analysis on month 3, you might say, hey, we're negative 400%
Yeah.
on our, but we're going to start gaining. So how do you manage that, and how do you sort of look at things differently so that you can say, okay, well, where will we be in a year? And how do we accurately forecast that, knowing that it's not a linear sort of progression? And at the same time, like you said, sometimes an educational project, for example, there are immediate gains as people immediately employed learnings that they got. And then over time, they kind of forget, and there's sort of a marginal drop off in how effective that is. That too, well, where do you draw the line, and how do you sort of model that and sort of understand what's happening? there's turnover, there's, other policies that are put into place. And so then we get into sort of an attribution problem again as well. So there are a lot of things to sort of deal with and try and figure out as you navigate this process.
Yeah. Yeah. And that would be obviously the notion that there's sustainable for the foreseeable future and all that. The third challenge you bring up in the book is that intangible and non-monetary benefits like quality of life and patient experience are often critical measures of success in improving the quality and efficiency of care, but they're difficult to include in a financial calculation like ROI. I think we've talked about this a little bit, but kind of expand a little more and then we'll move on.
Yeah, no, I mean, and we have touched on it, but it's the same idea. Whether or not you should do something is not just a financial decision when it comes to healthcare. And there are certainly examples one could come up with where you could say it was worth doing, even if you had a negative financial result, right? If it improved care and improved the lives of, a lot of people and had a huge impact, but you just not in a monetary way, you could say, well, we took a hit on that, but it was still worth it to do. So that makes it difficult. And again, compare that to manufacturing or sales or something like that. There's a hard stop at sort of, a return of zero. Anything below that, well, why would you do it? And here in healthcare, there might be situations where a negative return, at least in the short term or even in the long term, is worth it. So that makes it very difficult to sort of know, to answer the question that a lot of groups ask, which is, well, what's a good enough ROI? What level should I be shooting for? And it really, unfortunately, depends on the situation.
Yeah, it depends on your goal, right? Like, how do you quantify positive positive goodwill in the community if you're working
Right.
in hospitals or something?
Exactly.
Yeah. And then the fourth and final challenge here you state in the book is that there's a recent push in healthcare to improve care coordination across settings and between private and community-based organizations. So talk a little bit about that.
Yeah. So if we want to accurately reflect the value that is created and also the costs, we have to know everything that happened. And as we push to increase the coordination of care and integrate, inpatient care with community-based services and, rehabilitation and, provide people with resources that they can look to and things like that, it can be really difficult to sort of incorporate information from all these organizations if you're just one of these organizations trying to assess the value of whatever, activities you did. You may have to just estimate or make guesses at, well, we have anecdotal evidence that this many people also sought out these other services which they wouldn't have otherwise done, so that's a benefit for them, things like that. So it's just going to get harder as we continue to sort of integrate other aspects and ancillary services into care, as opposed to, this is our facility, we're going to run this intervention right here, it's going to start here and stop here, it's all within the facility, and we can control and know all the benefits and costs that are within the facility. The reality is again, as we talk about social determinants and access to care, a lot of times these quality improvement initiatives span, the entire care continuum, and it can be difficult to actually get and accumulate the data to really quantify that.
Yeah, because like you said, you're dealing with disparate systems oftentimes, right? Like somebody maybe from a different part of town might come to one hospital for one thing, but they're receiving their care at a place that's their ancillary care, maybe at a facility that's outside of that system. And how do you mend the two or mesh the two to come to a calculation?
Exactly. And it can be difficult too. I mean, even what's been done now, for example, hospitalizations. Well, a particular hospital may know about their facility, but they don't know about what happens at other facilities often. And so it really gets into, well, how are we going to structure it so that we can assess the value in the most accurate way?
Yeah. All right, we got a few more minutes left, but I want to pivot to this idea of how do we link value to something, right? Because value is subjective, and we can't get into determining ROI, determining the quality, unless we link the idea to whom is it valuable for, and then what are we going to use to measure it. So talk a little bit about like how we come up with the idea of measuring quality and then using surrogates for things like patient happiness or patient satisfaction?
Sure. I mean, so this is a little bit what we talked about in terms of, at the core of your ability to assess value and also quality is really kind of these basic um, concepts of measurement and evaluation. So we don't actually measure quality and we don't actually measure value. We measure surrogates, and the ability of those surrogates to reflect what we want them to reflect then informs our ability to actually truly assess quality and value. So, you know, all sorts of quality measures have been dreamed up, whether it's rehospitalizations or whether it's door to needle time for someone with a certain condition, whether it's length of stay in the hospital, whatever it might be. Those aren't actually that's not actually quality. Those are processes or those are outcomes that someone has says, hey, that's a good surrogate, which would indicate that someone received quality care. And the same can be said for the value. So our goal is to come up with valid and reliable measures, and those are technical terms and can cause some confusion, but really just are you actually able to measure what you want to measure, and how useful is that measure, how able is it to sort of distinguish between differing levels of quality or value. So sometimes when people push back on this notion of um, the value of care, what they're really pushing back on is, hey, I don't like your surrogate. I don't think that is a viable or reasonable measure of my facility's quality or the value that we provide. I would rather use something else for the following reason. So it really is a conversation at its core about the ability of the metrics that we have available to us to sort of be surrogates for quality and measure, which are not measurable things.
Yeah. Well, and how do we come up with those surrogates or those metrics? Are they coming primarily out of the academics, out of research, or kind of the quote unquote real world? Like how are we coming up with these surrogates?
Well, that's a good question. There's a whole industry on quality measure performance. The National Quality Forum has standards, and groups who develop measures go through huge pains to construct and evaluate and empirically test different measures to make sure that it's capturing what it's supposed to capture, that the measure can distinguish between groups that they know are actually different, to test how well that measure does. It's submitted to a governing body like the National Quality Forum, who says, yes, that's a reasonable measure to use, or no, it's not. And a lot of times, for many of these measures, there are a million things to think about. Who should be excluded from this measure? Whether it's a measure about cardiovascular health, maybe you exclude people who have valvular problems because they don't apply for that. It's not reasonable for them to receive the same type of care as someone else in that group. Things like that. So the inclusions and exclusions of who's in that measure, that whole process is a huge, complex, ongoing program that people have been working on for years and years and years and years. So there's no perfect way to do it. It comes from experience. It comes from expert opinion. It does come from academic research and literature, but it can be difficult to come up with those for sure.
Yeah, because I'm sure that testing it too is difficult. Like I'm thinking about some of the research that I've been involved in at the university, and the idea of like taking this surrogate and linking it to what you did and the outcomes it just gets very hairy very quickly. Unless you have like a degree in statistics or something like that, it can be way over the head of many folks.
It's hard. I mean, and even within validity and reliability, there are a bunch of different types. Whether you're talking about if someone's abstracting information from medical record, there's retest reliability. How likely is it that if two separate people abstract that information, they're going to get the same results? The higher that likelihood that is, the more reliable that measure is. Or how valid is a metric? Let's link it to how people perform on this metric. Is it associated with how they do as an outcome? Are they more likely to get an infection or recover or whatever? Then that sort of speaks to the validity of that measure as actually measuring quality of care, since it's linked to whatever outcome they get. And you're right, a lot of it is very heavy in the empirical and statistical parts of it. So especially the ones where you get into patient-reported outcomes, and you're
Yeah.
developing questions, and they have to respond, and you want to show that they're actually getting at what you want them to, and you have to deal with recall bias and all these sorts of things. There's a whole industry out there about the science of how to do that.
Yeah. Something that's way over my head. Well, this has been great, Craig. If you could just give somebody maybe like one or two big points that you'd want them to walk away from this conversation, what would they be?
I think the biggest thing that I tell people is to think about the value assessment upfront. It's too often people will do a quality improvement initiative or something and think of it after the fact, and then they realize they don't have the data that they need to sort of assess it. So I want people to start thinking of quality and value together. They're related, how they're measured, things like that. So that's really the big takeaway for
Yeah,
me.
it's
And the
not an
second,
afterthought, right?
yeah, and then the second one really is the fact that value is larger than ROI, and value means different things to different people, and we really need to start talking about what do we mean by value in the specific situation when we talk about it.
All right, great. Well, thanks for being on the show. If people want to find out about you, about your work, maybe want to purchase your book, where would you send them?
Sure. They can Google me, Craig Solid, and I'll probably be one of the top things that come up either on LinkedIn. My website is solidresearchgroup.com, and there are links to the book there. You can also, it's available on Amazon. Just go to Amazon and search for Return on Investment for Healthcare Quality Improvement, or directly from Springer. You can go to springer.com and search for the same thing.
All right. Thanks.
Thanks very much for having me.
Well, I hope you enjoyed that conversation with Craig Solid about return on investment and how we can justify the cost of an initiative. It might not seem initially a financially, viable option or a financially viable initiative to employ. I think what is most interesting to me about conversations like this is not so much the ROI piece and the quality improvement piece, although that is important, but it's this idea of value. What is valuable? What is valuable to you? What is valuable to me are going to be different things because value is inherently subjective. And we mentioned it a little bit, especially in the healthcare space where there are so many stakeholders at play. There's payers, there's administrators, there's clinicians, and then there's the end user, the end recipient, which are the patient. And understanding all of that is hugely important when it comes to making decisions in your own clinic, in your own organization, not just from a standpoint of how do we balance what is sometimes and what can be opposing views or opposing points of value for different stakeholders in order to develop some sort of system or some sort of method that delivers care that's of substantial quality, that's of at least clinically competent quality, that's going to get the outcomes that we desire, but in a way that is seemed as valuable by the end user and doable, and again, valuable and probably fulfilling on the side of the clinicians. It's the whole topic is very interesting to me, and I think we as healthcare providers, healthcare administrators, spend a lot of time understanding the financial numbers. We understand at a very basic level the ROI, if you would, of implementing some kind of initiative. But when you take into account, one, the different stakeholders, and then two, that subjective piece, that value is subjective and it is going to vary depending on which stakeholder is looking at an initiative or looking at an outcome, it makes it a whole lot more murky. It makes it a whole lot more interesting. Humans are complex beings, right? So that's all I got to say about that. If you like the show, head on over to iTunes, give us a rating and review. It helps people find us, helps spread the message, helps spread the show around. You can head on over to www.betteroutcomes.show, and there you can see all of our past episodes, connect with all of our guests. There's links to their websites, their LinkedIns, Twitters in some cases. You can also sign up for the newsletter there, and what we do is we shoot out an email every time we post a new episode, and that way you don't miss it. Or you can find us on any one of your favorite podcast players, Stitcher, iTunes, Castbox. What are the other ones? It seems like they're popping up like weeds. All right, folks. Until the next episode, be safe, be healthy. I will talk to you then.
Thanks for listening to the Better Outcomes Show, where we explore the possibilities of a new healthcare. Our hope is that you walk away from each episode informed, equipped, and empowered to push the boundaries in your own practice or business. We want to give you the tools to help you build strong, long-lasting relationships with your patients and clients, helping meet their goals, improve their health, and achieve better outcomes. Learn more at www.rehabpracticesolutions.com. We'll catch you on the next episode.